All right, we are live.
All right, thank you. We are back after break. It is about 10:58 on April 14th. So we are going to continue our testimony on S-120, S-132. And we have with us Ina Backus, who's the Director of Healthcare Reform from the AHS. We have a list of folks, so we'll keep moving right along, and people who have already testified who are also listed for 132 will not, we won't have you back because we've asked you to do all your testimony at once. So I'm looking for, I don't see Ina. Oh, there's sure. Ina Backus is here. Ina, are you here? Good. All right, terrific. You're in the room. Thank you for being here, and we'll listen to your testimony. And again, for all folks who haven't been in the room until just recently, please provide what you can of your testimony in writing to Nellie, and we'll get it on our webpage so we have everything together. So welcome. Go ahead, Ina.
Thank you, Madam Chair. For the record, my name is Ina Backus. I am the Director of Healthcare Reform at the Agency of Human Services. I wanted to take first looking at S-120 and the committee's discussion this morning with amongst yourselves and with witnesses about your priorities regarding affordability of healthcare. I think there's some important context to consider for the work that is proposed within S-120. As you may be familiar, the American Rescue Plan Act has recently provided for some considerable and significant movement with regard to the cost of healthcare coverage. That will be true for Vermonters. ARPA is considered at this time to be the largest reform package since the implementation and passage of the Affordable Care Act in 2011. ARPA greatly expands the ACA's Premium Assistance Program for enrollees in qualified health plans through health insurance exchanges and will result in many millions of dollars of impacting individual health insurance purchasers in our state. Not only does this law expand eligibility for premium tax credits that offset the cost of health insurance, it also reduces the amount of household income known as the contribution limit that should be spent on health insurance. These are significant federal level changes that are going to have an impact in Vermont very soon. These changes have an impact on the purchase and affordability of health insurance in our state. And in light of this change, legislation has been created to modify Vermont's marketplace so that small businesses who are purchasing insurance can also benefit from reduced premiums after being decoupled from the individual market, where there is going to be so significant of an influx of federal assistance for healthcare coverage. The impact of these policy changes is going to be very real, but it should be measured and monitored and considered in the constellation of other healthcare reform initiatives. And I think there are some important things to keep in mind regarding this change. First, that Vermonters are going to be notified of these new subsidies this spring and will have the opportunity to apply for them as a discount on their monthly premiums beginning this summer. Those who are enrolled with Blue Cross are already receiving mailings as of Monday, and those with MVP receiving mailings in the coming days. Small businesses that are decoupled from the individual market should also experience tangible reductions in the cost of health insurance premiums for the 2022 plan year. Because these subsidies are available currently for 2022, and we need to monitor and understand the extent of the reductions. We need to remain nimble in the case that the subsidies are not extended beyond 2022. And we need to be very creative in how we think about these subsidies in terms of the overall picture of affordability for Vermonters, particularly if the subsidies do indeed remain beyond 2022, which there is quite a bit of speculation that these subsidies could be made permanent in the future. But they are here now and should be considered in the context of the work that the S122 proposes with respect to affordability. Moving now to S132 and the discussion that I've been following along with this morning, which has been of great interest. I first wanted to speak to the question that's been raised a couple of times regarding the requirements of the all-payer model agreement for there to be a proposal related to the integration of Medicaid services, specifically Medicaid, long-term services, home and community-based services, and mental health and substance use disorder services that are not currently a part of the total cost of care or the financial target services for the model agreement. I want to be very clear that our federal agreement asks that the state submit a proposal for how these services could be integrated into financial target services for a next or subsequent model. That proposal does not, we're not required to propose that they are integrated. We need to consider the pros and cons of integration of those services. And we've also been asked to consider those pros and cons in tandem with considering the potential targets for a next agreement, which very well may change from the targets that we have today. It's an open question about how the next agreement will handle targets for healthcare cost growth. And so again, I don't want it to be misconstrued that it is imminent and required that in a next agreement, these services, these Medicaid services are subject to the same financial targets that they are subject, that other services are subject to in the agreement today. It is in the hands of the state to propose something that is prudent, that is responsible, and that certainly supports our Medicaid services of this kind. Speaking at a high level about S132, S132 proposes quite a many of different health policy interventions in a number of different arenas. My overall feedback with regard to that approach is that the approach is not necessarily consistent with our need to focus on implementing the all-payer model implementation improvement plan and improving our performance in our all-payer model agreement. We are working with our federal partners in Medicare, as you know, in a very specific and customized arrangement for the state of Vermont for Medicare to be a partner with us in transforming healthcare payment and delivery. That partnership is important to maintain. That partnership is important for us to be able to evolve in future or subsequent agreements. We have seen a federal commitment to moving away from fee-for-service, as we've discussed before, and we understand that the federal government will continue to push in this direction. And as other witnesses have really aptly noted, we're really poised at this time to be able to harness federal partnerships across Medicare and Medicaid to really maximize our state's flexibility to evolve and to approach payment and delivery system reform for in the long term, and in a way that will allow us the time necessary and to do the work of transformation in the payment and delivery system arena. These models, like I said, in partnership with Medicare, we are in a position where we could potentially evolve how the state partners with Medicare. We need to maximize our performance in our current agreement so that we're in good standing in that partnership, and so that we can focus on demonstrating results through this model. I also think it's important to note how significant our progress has already been in moving away from fee-for-service reimbursement through the all-payer model. While we want to improve and push ourselves further and more towards a fixed prospective payment aspect of our model, moving away from fee-for-service is a stepwise process. Payments that are attached to quality and value are considered value-based payment, even if those payments aren't a fixed prospective payment. And Vermont has made significant progress through our federal state agreement in adopting value-based payments. I think there's some important highlights to note about how we're performing in this agreement and why it's very important that we continue to have commitment to focus on the payment and delivery system work that is happening through this agreement, and how we can advance in the future. More than 80% of Vermont's Medicaid enrollees for whom Medicaid is the primary payer are attributed to the ACO and aligned to a value-based payment model and this includes fixed prospective payments. Vermont is only one of 2 states nationally that has a payment model that meets the healthcare learning action payment network criteria for being the most advanced value-based payment model. So we have made headway here, and we are well positioned to continue in this vein. Fixed prospective payments, as I said, are not synonymous with value-based payments. They're a mechanism that can be used in value-based payment models. Our improvement plan is very focused on advancing this mechanism. In particular, the Vermont all-payer model agreement, in fact, has no requirements in of itself for fixed prospective payments. Instead, the agreement requires that an ACO offer a value-based payment model that includes the possibility for shared savings if it achieves its goals related to quality of care or utilization. Vermont providers who are participating in the Medicare ACO program are currently rewarded by Medicare as participants in advanced alternative payment models, consistent with that framework for moving away from fee-for-service, consistent with Medicare's program for quality payment, paying for value through Medicare rather than paying fee-for-service. Again, we need to be able to focus our activities on continuing to push away from fee-for-service, broadening value-based payment models further, even though we've made significant progress, and including our broad group of stakeholders who are working very hard to implement this model. Healthcare transformation does not happen overnight, and we have had a global health pandemic that has sat in the middle of the implementation of the all-payer model. It has disrupted, as you know, all of our lives to some degree, and has certainly disrupted what has been the ordinary way that the healthcare system works in terms of the delivery of healthcare services. We want to be able to focus for the remainder of this agreement on continuing to progress towards value-based payment and delivery system redesign and reform. I think it's important to note that, again, our federal partners have been committed to value-based payment along with Vermont for years now and spanning multiple federal administrations. The current federal administration is still settling into its leadership. The current federal administration still clearly is operating the Center for Medicare and Medicaid Innovation. There is speculation about what the priorities for our federal partners might be, but certainly our federal partners, again, have been committed to payment and delivery system reform now spanning multiple administrations. There's a recent commentary, it's an opinion piece that comes from Donald Berwick that was published in the Journal of the American Medical Association, JAMA. This is an opinion piece, but it is setting a vision from a healthcare thought leader for CMS and CMMI, specifically the Center for Medicare and Medicaid Innovation. It's setting a future vision for that and making some pretty bold recommendations in this opinion piece. But the recommendations suggest that our state certainly is well positioned to work with Medicare in the future because of the progress we have made to date, because we are so aggressively pursuing value-based payment. I'll just read a little bit of this recommendation now, one of the recommendations in the piece, so that you can have an understanding of where this opinion is landing in terms of CMS and CMMI's authority in particular. A recommendation from Donald Berwick says that CMMI should use its authority to scale the ACO model nationally by making it mandatory for all Medicare participating clinicians and hospitals. Clinicians, hospitals, and payers find it difficult to operate in an ambiguous world straddling payment for volume and value. Although voluntary participation has made evaluation of ACOs difficult, the Medicare Payment Advisory Commission and others have concluded that different CMS ACO models during the last 15 years have consistently produced modest savings for CMS. CMS should gradually but steadily expand ACO adoption during the next 5 years until virtually all Medicare participating organizations and clinicians are operating within accountable care organizations. Advanced primary care practice models will be a natural core feature. Part of the expansion should include, as much as feasible, progressing to capitation of ACOs for total cost of care. I share this recommendation because Vermont is in a unique situation where we have a federal partner, we have a special agreement as a state where we can work flexibly with Medicare, hopefully towards our goals as well as Medicare's own goals. As Medicare moves to be perhaps more mandatory in how it sets out its payment and delivery system reform agenda, I think it will be critical that Vermont have an avenue for us to continue our work as a state, that is customized and that is reflecting our state's unique characteristics rather than only working within federal constructs that are prescribed and that are perhaps mandatory for us to operate within. We've been able to customize the ACO model to date here in Vermont in a way that meets the objectives of our state much more critically than if we were working with an off-the-shelf model.
Okay, thank you, Ina. Any questions of clarification at this point? I'm feeling a little bit pressured because we have 6 more folks and our time is getting limited, but Senator Hardy, you have a question. Go ahead.
Well, I mean, thank you, Senator Lyons. There was a lot packed in there, and we've heard a lot from Ina over the last few weeks. I guess I would just disagree with a lot of what you just said, and am concerned to hear that you're tying so closely the global commitment renewal waiver with the continuation of the ACO model, given all of the concerns that we as legislators have heard about the ACO model. And I just, we have struggled over the last few weeks about how we can provide some kind of guidance or input into the global commitment waiver renewal, which is happening during the off session, and that I know you'll have a lead role in putting together. And I guess I'm just concerned and wanted to note that after hearing your testimony. But I also want to hear from the other people who are on our screen, because they haven't had as much chance to speak to the committee.
So we're this testimony is specifically directed toward the two bills that we're looking at. And so we're going to continue with that. And we're hearing from folks who have asked to testify. So that is important.
I know, but that testimony was not specifically directed to the bill. So that's why it brought up a lot more than that. So that's why.
So Senator, we'll get the testimony on our webpage, and we'll have our discussion after we've heard all the testimony. It's, everyone has an opportunity. And I'm going to turn to Corey Gustafson and Nissa James. Are you together providing testimony together, or are you providing separate testimony?
No, we can be on together.
Okay, good.
Yeah. And Ina went through a lot of the pieces that I think we had to contribute to the conversation, senators. I would like, from listening, to just make the comment that there's buckets when it comes to healthcare that it seems like we are jumping back and forth between, and I think it's helpful when I think of the buckets to really get my arms around what are we trying to accomplish here? What problem are we trying to solve? And if you'll be patient with me, I won't take long, but I'll just say there's healthcare financing, and then there's payment and delivery reform. And the financing is how much does your insurance cost, or how much gets paid into a healthcare system. I hear everyone regularly say how much healthcare costs, the cost of the premiums, the cost of out-of-pockets, the inflation, and all true statements that are problems we want to solve. But on the other hand, then we talk about payment and delivery system, and like last week I was in, and we were talking about how much gets paid for a certain service, and it's not enough, and that the discrepancy between what we pay for healthcare and how we pay for healthcare is really the sort of separation I just like to raise and make and say that that's really in our minds where Ina had a lot of the points I would have made about the Biden administration, the future as it really pertains to health reform. A lot of the things we are doing are being held up in this federal environment as this is the way forward for healthcare. That isn't to say that we don't need to pay attention to what the implementation of our efforts here on the payment and delivery side. Maybe I'll pause here and just say, on the healthcare financing side, the American Rescue Plan has really changed the game. It's a game changer of incredible magnitude, getting rid of the cliff. There's a couple of little things, the family glitch, there's other pieces that are still to be determined, discussed, and addressed. But in terms of financing, this could be an incredible game changer. And I'll just say this, we're in the process of implementing those changes so that Vermonters for at least these 2 years can get access to those increased subsidies. And like Ina said, if those were to continue, I mean, we really have to think about how we talk with our Vermont businesses about providing healthcare coverage, because the level of support that would go into people's premium payments would be incredibly large, and so paying attention to the financing side, executing as we are, DEVA is responsible for the implementation of the exchange effort. So that is going to be something to really pay attention to, but that's on the financing side. So a lot of this conversation, though, has been on that, the reform side. And, I think we're looking at it like whether it's a success or failure today, and that's really not how we look at it. For fear of being redundant with Ina's testimony, but it's really, we only have one story. That is, we know fee-for-service has inherent motivations and incentives for the provider community without any regard for what the cost of that service, the total cost that comes together at the end of the day, without any regard for that in terms of, or any, I hate the term, but it's just the most clear, any skin in the game. And that is what our effort at Medicaid, I'm speaking for Medicaid, not the whole all payer effort. At Medicaid, we have set the principle that we wanted to get away from fee-for-service, and we wanted to produce a more aligned healthcare system. And we have done that. I mean, we have moved in that direction. Is it perfect? No one would ever say that. And I would hope no one would ever say that about anything. We're always about continuous improvement. It's our third priority at DEVA for expansion and improvement in what we do. We are continuously looking for improvements. I would assume healthcare reform is a similar process in terms of looking back, it's always evolving. So I would not say, I'm struggling a little bit because I keep thinking of a few of the comments that were made in relation to our effort of getting away from fee-for-service. So we've made prospective payments, alignment. We want alignment. Care coordination is part of alignment. A lot of what we pay for to the ACO as part of our purchase is for that care coordination and alignment. The comments that you've heard, some of them are close to the reality, and some of them are pretty far off the reality. I'll pick one comment and I'll just tell you that the ACO is absolutely not trying to build its own cadre of care coordinators or its own care coordination system. They're here to provide technical assistance, training opportunities, and care model implementation. And they have intentionally, understanding what we are in our state, and that we've had a long history of care coordination. Let's go to the blueprint started in our mid to late 2000s. We've been very concerned about primary care and care coordination. The ACO is supposed to build on that and create even more standardization, alignment, intersection, and they have intentionally tried to build on that local and existing care coordination infrastructure that exists in the state. So I really understand the fear of that comes with, someone else is in charge and it's not the legislature or it's not the Green Care Board or DEVA, but it isn't quite true. It isn't quite true to say that they're trying to build their own independent system of care, or that it's privately held. I mean, we are in control of their contract, and to say that they aren't the only possibility. We just put out a renewal for an RFP for our Vermont Next Generation Medicaid program, ACO program. Any ACO can come into that and bid on that opportunity. We have intentionally not built it for one provider or one entity alone. We have intentionally built it in a way that it gets what we want, which is, again, movement away from fee-for-service, accountability for the dollars that are paid, quality accountability, and risk accountability. That risk is what is a difference from the fee-for-service, right? And we want to pay prospectively. I want to pay prospectively because I want both our budget to be manageable, not the ups and downs, and I want the providers to know they have money in order to provide the services, to pay their people. So, I hope it doesn't sound like a lecture. It's a little bit of like a defense of we know what our principles are, and we'll keep moving towards that. If the game changes, I mean, the execution and implementation that we've been engaged in at DIVA was built on the agreement signed by the previous administration. Governor Scott evaluated that agreement in this first month in office. We had a conversation, and it made sense, right? Trying to create alignment. We'd heard from many providers saying, look, every insurance relationship seems to be different. It creates requirements, differential requirements. So we said, well, let's try to get it together. And I'll remind you that this is only, well, I'm into my 5th year, I guess, as the commissioner of DIVA. But really, I mean, this is just so the beginning of this process in my mind. And so I would just say, you're not going to get any reform effort that creates a situation where you say, oh, 3 years later, oh, we're all done. And I don't think anybody's expecting that. So I'm just saying that, you know, where we see issues and where we see areas for improvement, we're all for making those areas better. I will say we do have our experiences, and we have our reports on the Medicaid experience. The 19 report is the latest report. So for year 19, that's the latest report we have. Don't forget, I know you don't, but 20 is all COVID all the time. But we even made adjustments in that, and we got the feedback that our agreements in 20 were really important in keeping our healthcare system intact for Vermonters during a health pandemic. So, but just to get back to the 19 report, quality was improved. That's in the report. We've seen that providers that get prospective payments, they spend less versus the estimated total cost of care than providers that are paid fee for service. So we're getting this feedback. You couldn't get that kind of data without actually implementing and seeing a system work. We would like to see and I'll just say this as I guess I'll close, because I know you have time constraints, Senator Lyons, but I'll just say this, that even if the all-payer model doesn't continue, I still believe in getting away from fee-for-service. I still believe in alignment, and I still believe that we need a provider-based entity to lead those contractual and those relationship efforts and that care coordination effort. It seems to me that in Vermont, we want efficiency, but we want local control. We want everything to cost less, but we don't want it to come with the kind of movement that really required to create this sorts of efficiency. I mean, if you could put everything in Medicaid's control, then we would spend what we had to spend, right? We would have the state budget. Anything you want Medicaid to spend less, you get it in the budget, and then that gets put out through the Medicaid program. Obviously, that's a relationship between the state legislature and the governor's office, but you understand my point that, like, we can spend more. We just don't have necessarily more to spend always. And so I would just say we're trying to reform the healthcare system by paying differently, and hopefully it creates a better product for the Vermonter that uses the system, and it creates an aligned system that's better for the providers. I think that the one other comment that I heard was, there's some entities that say the data models and the data tools aren't that valuable to some providers. And that might be because those providers are on the front line, and they're the ones that might have the best information about what social determinants are really impacting a certain individual. If that information, I've heard some providers say, all I do is feed information in. And I think to myself, oh my gosh, I think that's what I want. I want to know, or the system should want to know, maybe not me, but that's what the system should know. And so that when some acute, episode happens, that the provider that is treating has all the information at their fingertips. And so, I think I'll stop there. I know I really didn't talk about the bills, but those bills seem really geared towards this, this sort of theory of the case that we've been trying to implement. That's, I guess, right.
So, Corey, thank you. And I think, and I'm thinking that you have and NISA are representing the same information.
perspectives. If you had technical questions about the
Okay.
sections of the bill, that that NISA was really prepared to talk to those.
Okay, what would help, I think, at this point is if you would please send your written testimony with specific comments on the two bills, because I think we're moving into an area of discussion, and we want to keep it at a level of talking about the bills. So, but
Yeah,
I do,
that's
it's okay.
so can I just
thank
say
you.
this though, is like if we had specific comments, I mean, one of the issues I just think is really important. The reason I sort of say all the about the effort is it, I kind of agree with a few of with your the testimony earlier where a national system of healthcare would create a lot of efficiency in this country. There's no doubt about that, but we don't have that. And we have, as a state, we've walked up to that precipice. Not this administration, a previous administration walked away from that, understanding the complicated nature of it. So, if we're in that situation where this is where we are, we should probably not, and this is really to the bills, Senator Lyons, we should probably not do things that makes it less likely we can implement and execute on what we're trying to implement and execute right now. And if we increase
I'm
the
going to
level
ask that we move on, simply because we're running out of time, and we've got about four other folks who need to testify. Senator Hardy, quick question.
Thank you, Madam Chair. Commissioner, thank you for your comments. I just want to clarify something. I don't think any of us are disagreeing with moving away from fee for service. I think you and your team have provided compelling testimony about why we should do that and our progress in making that happen. So I just want to be clear that, my concerns are not about that. And
that's good. That's perfect, Senator Hardy.
Right. Well,
okay.
And I think that the reforms that you're talking about sort of generically or, broadly are super important. My concern is that we hear a lot about payment and we hear a lot about providers, and this is clearly a payment and provider based reform effort. And I want to know, how can we fit patients into that model? And I think that one of the things that we're trying to do with S120 is to really hear from patients and hear what they're experiencing and how we can include them in the reform efforts, so that we make sure that their experiences when they go to the doctor, or if they can even get to the doctor, are taken into consideration. So it's not just about payments, it's not just about providers, that it's also about patients. And so I just want to be clear about that. And we're way off the bills now, but that's really part of the intention of S120.
Senator, we understand that what you're saying. And obviously, I think that everyone wants to reduce costs for patients and to ensure primary care and prevention access, and access for social services, and access to acute care when it's necessary. So that is the goal. And so we're going to continue to hear from people who have our concerns. And first, I want to say thank you, Commissioner Gustafson, for being here and for your input. I think we could have a lively dialogue going forward. Thank you. I'm going to shift over to Mark Hagee. Mark? Are you here? Yep, there you are. Thank you for being here. And you're muted.
Thank you. I think I'd have that down by now. Appreciate the opportunity to testify. For the record, my name is Mark Hage. I'm the Director of Benefit Programs at Vermont NEA. I am also a former public school teacher. I want to begin by testifying to S132, and then I want to speak briefly to S120 at the end of my remarks. In respect to S132, I want to express my support for some very key measures in the bill. First, expanding access to primary care without cost sharing. Thank you. Primary care is fundamental to an affordable and equitable healthcare system, and placing such care under a deductible or any kind of high out-of-pocket charge, which is often the case today, runs counter to providing cost-effective value-based care to every Vermonter. In fact, I would urge the legislature to direct even broader measures in this regard by removing primary care from cost sharing altogether, and to declare that the physician shortage in this field is an urgent public health problem that must be resolved. We also support health insurance coverage for hearing aids. This is an issue I hear about from my members every year. These devices, as you well know, are prohibitively expensive, and their unaffordability has a profoundly negative effect on the lives of the hearing impaired. And for me, hearing aids, like primary care, also fall into the category of value-based medical services and devices. And I would also urge that they not be subject to a high deductible or a high out-of-pocket charge. I taught hearing impaired students. I know the difference these devices make in their lives, not just to the quality of their lives, but as Patrick Flood noted, also to their health. And I also watched my father struggle with this issue. I also support the provision in the bill that calls for analyzing increases in health insurers' administrative expenses over the most recent 5-year period and how those increases compare against the consumer price index. That makes eminent good sense. In respect to holding the Accountable Care Organization more accountable and transparent, may I say I find it deeply problematic that a large hospital-centric institution that does not deliver medical care, but is demanding more transparency and accountability from doctors who do, must be compelled by law to turn over its financial records and other documents to the state auditor. An organization committed to the public interest should have done that as a matter of course. But I'm very grateful that you are compelling it in this bill. More generally, I'm at a loss to understand how the bill's provisions in respect to the ACO would dramatically alter the status quo to the benefit of Vermonters and our healthcare system. To serve the public interest in the truest sense, the ACO would need to prove first, it is committed as its core mission to making healthcare accessible, affordable, and equitable for all, and then be able to prove to us that that is actually happening. Respectfully, I see no evidence of that. Indeed, quite the opposite. Many Vermonters, including school employees and their families, are struggling mightily with the cost of healthcare and health insurance. The costs of the healthcare and health insurance systems continue to rise as the ACO continues to extend its reach and influence into the healthcare system. I believe as our healthcare system's finance and delivery system becomes increasingly more centralized under the umbrella of one ACO, with or without changes called for in S132, that this dynamic will inevitably drive up prices and exacerbate the unaffordability and the inequity of healthcare. Patrick Flood mentioned other provisions in this bill related to contracts and fee schedules, et cetera. As with Mr. Flood, I don't have any issues against all of those. However, I must say again, I can't see how these changes will bring us any closer to achieving the goals of Vermont's first principle of healthcare. Quote, to ensure universal access to and coverage for high quality, medically necessary health services for all Vermonters. Systemic barriers such as cost must not prevent people from accessing necessary health care, and all Vermonters must receive affordable and appropriate health care at the appropriate time and in the appropriate setting. Most Vermonters have no idea what OneCare is or what it does, but they do understand that health insurance costs are hurting them, their families, and their employers, and they see no relief in sight. According to a report from Vermont State Auditor from 2013 to 2020, Blue Cross's premiums for individuals, families, and small businesses increased an average of 65.6%, while the median family income over the same period rose by just 18%. Vermont's 2018 Household Insurance Survey reported that 36% of Vermont adults under the age of 65 were underinsured. And when it comes to our uninsured population, whose numbers have very likely risen during the pandemic, their plight is not addressed by OneCare. Ultimately, to lower costs and expand access to care, we got to go to the root of the problem. That's hospital costs, it's specialty care costs, prescription drug costs, and administrative costs. And as a hospital-based entity, OneCare's best interests are not served by fewer hospitalizations, less specialty care, or lower administrative costs. For these reasons, I believe Vermont would be better served by transitioning out of the ACO by the end of 2020 to a model of healthcare delivery that is financed and regulated differently, and that this can be accomplished, I'm confident of this, without sacrificing the quality or the coordination of healthcare. More specifically, strengthen current systems of care coordination and quality evaluation at the state level that existed before OneCare. Put it in the hands of public servants and direct that this critical work be done in partnership with the medical community. As Commissioner Gustafson noted, we have a long, successful history of care coordination in the state of Vermont. These folks need more support and more funding. We're talking about a robust system of coordinators in home health, in the agencies of aging, in community mental health centers with SASH and the Blueprint for Health and others. Again, they existed before OneCare. They're oriented toward community-based and prevention-oriented care. Let's give them more resources and support so they can continue to do the good work that they know how to do. And additionally, I believe DVA can go back to handling all Medicaid funds in the absence of an ACO, the way it did before OneCare. Once again, I have to stress, taking decisive measures to rectify the shortage of primary care doctors and allocate the resources needed to strengthen primary care is essential. I would also, and Ed Paquin spoke very eloquently, I think, to that public nexus of finance and regulation. I would urge us as a state to finance healthcare through a system of global budgeting that is fair, sustainable, transparent, and subject to public regulation. Renegotiate the all-payer model to permit Vermont the flexibility to align standard billing practices and fees for Medicaid, Medicare, and commercial insurance carriers, thus facilitating the transition to global budgeting and a fair price setting system. I would also urge the establishment of a prescription drug affordability board, as Maryland has done, to leverage the power of state government to control the prices of high-cost medications. The pharmaceutical industry and PBMs, this is one of the most predatory corporate sectors in the economy, and they are leeching the life out of the healthcare system and out of the lives of working people. And much more systemic reform is going to be needed to ultimately overcome that problem. But I believe there's steps we can take here in Vermont to address it immediately. And one of those is the establishment of a prescription drug affordability board, and Maryland has showed us the way to do that. So I'll close my comments there in S132. In respect to S120, I want to say emphatically that Vermont NEA very strongly supports this legislation. We have been in collaboration and conversation with a number of other organizations that feel the same way. We've not had an opportunity, I believe, to testify today. That would be Rights and Democracy, AARP, United Professions of Vermont, and VPIRG. All of us want to see this bill pass, and we want to see that conversation at the community level about what we need in healthcare, what kind of reforms will actually make a difference to take place. My members really like this bill, and they want to be part of that conversation. So thank you for having the chance to talk to you about both bills today.
Thank you. And please send us your testimony. Send your testimony to Nellie so we can have it.
I will do so. Thank you, Madam Chair.
Yeah, appreciate it very much. And we have a long list of people wanting to testify, and we're only hearing the beginning of the list today. So Jessica Morrison is here from the Vermont Workers Center. I don't know that we're going to be able to get to both Susan Barrett and Ruby Baker, but we will make every effort to put you on the agenda. If we don't get to you today, tomorrow we can add some time in at the end after we've done some work on our childcare bill. So we'll try to find that time. Nellie, this is a heads up for you. Jessica, welcome, and thank you for being here. So we will listen to your testimony.
Hi, thanks for the opportunity to speak. Like you said, I'm from Vermont Workers Center, and you heard from Ellen and Grace earlier on 120, and I'm going to speak more to S132. As to introduce myself, I'm a Worker Center member and a nurse practitioner living in Burlington. And so I think S32 is that it appears to attempt to address some of the problems with the all-payer ACO model that have come to the attention of legislators over the years. And we actually have a more fundamental set of concerns about the model that this bill does not address. Our most fundamental concern is that the ACO model doesn't help people with the major barriers we face to access and afford healthcare. Like our Kate just said, if you're uninsured, it doesn't do anything for you. If you have a high deductible plan, it doesn't do anything for you either. And if your insurance doesn't cover something you need, it doesn't solve that problem. And it's not that it doesn't solve these problems well. It's that it can't because it's not designed to. In addition, there's been a lot of talk today already about primary care, and OneCare is supposed to increase access to primary care. However, we're actually seeing the opposite, that small primary care practices have been increasingly shutting their doors all over Vermont over the past number of years. And I'm actually one of those primary care providers that was driven out of practice myself. And I can tell you how challenging it is to stay open and continue to provide care to people in your current system, no matter how committed you are. I became a nurse practitioner because I really wanted to help people with prevention and wellness, but the reality is the increased squeeze on primary care providers, both financially and with administrative and documentation burdens, just doesn't give the time to do this. And it's burning out more and more providers like me who are trying to give quality care in our communities. And I think we gave very high quality care at our practice, and it was really heartbreaking to have to close because the system wasn't set up for us to thrive. And the ACO likes to say that capitated payments are the solution to this, but I've seen the rates that they pay, and I can tell you that the current rates that they're paying just would not even come close to covering our operating costs or allowed for spending more time with patients. And ACOs are also based on the assumption that payment reform will somehow bring down the cost of healthcare. And I think we have to ask ourselves, has that happened in the years that we've had ACOs in Vermont? OneCare is an experiment that's been going on for 9 years now, and it really hasn't succeeded in making healthcare more accessible or affordable. And on top of this, Vermont's ACO, OneCare, is one of many ways that UVM Medical Center and Dartmouth-Hitchcock are advancing their monopolization of healthcare in the region. And we're supporting this effort with public money through the ACO. We really can't expect that a private company is going to represent the best interests of people in Vermont. And monopolies are hardly the road towards affordability. You may be aware that in California, currently the Attorney General has sued the Sutter Health Network for using its regional dominance to drive up healthcare costs. So really think we're headed in the wrong direction in terms of affordability with the ACO model. And since the all-payer model agreement was signed, Vermont has siphoned now billions of public, mainly Medicare dollars into this private corporation. And Medicaid is a public program that's been a lifesaver for so many people in our state. And it shouldn't be privatized. And in fact, we should be going in the opposite direction by making healthcare a public good for everyone. So to sum up, we don't think that saving the ACO model through some of the measures that are proposed in 132 is going to address the challenges we're facing in providing healthcare to Vermont residents. Rather, we need a totally different approach that ensures that everyone can get healthcare. We urge you to listen to the voices of your constituents and seriously consider alternatives that can actually serve the health needs of our communities. And we think that S120 isn't more in a position to to advance that. And we really urge you to have a public process around that so that more voices can be heard. So I'll leave it there, but thank you.
Jessica, thank you. That was very clear and helpful. And so if you don't mind submitting your testimony for us, we'll have it on our webpage. So thank you. All right, what I'm going to suggest now, committee, is that, and I'm going to look to Susan Barrett, you are here, and Ruby Baker, you both are here to testify. We only have a few minutes left today, and thank you, Chair Mullen, also for being here, and Elena Berube, the team from the Green Mountain Care Board. I just want to say, when yesterday was a very difficult day for us with our inability to do appropriate scheduling, so we are overscheduled, which is unfortunate. Doesn't always happen in this committee, but it did today. What I'm going to suggest is that and I'm going to look to each of you, Ruby, Susan, Kevin, Elena, is tomorrow morning, late in the morning, a time when you may be able to come back in and Zoom back in?
So having been in your shoes before, Madam Chair, I understand the predicament you're in, and we'll make it work
Okay.
for whatever has to be done.
So let's do that, and Nellie will reach out and try to ensure that there's sufficient time. I'm trying to think that we'll need probably a half an hour to 40 minutes, and we'll make that happen so that you all can provide your testimony, and we would like to hear it without being rushed into 2 seconds. Okay, and I appreciate your understanding on that.
No problem.
All right, Ruby, is that something that you can live with, or?
Yep, I'll see you tomorrow.
Terrific, thank you. And I know Kate Logan was also with us on Zoom earlier. And so Nellie, we might have you reach out to her as well and see if we can get her in. Okay. All right, so committee, tomorrow we're going to spend our time on H-171. It is absolutely imperative that we get that bill out as soon as possible. So we'll be working on that. So take some time. As I said, when we first got on, I do have some language from Sarah Kenny, which we may or may not include, but I'll make sure that Jen Carby has it and that we can look at it. We'll put it up on the webpage. I have Nellie put it on the webpage. And then if you have any specific recommendations for improvements to the bill, we can also look at that. I think I have one, maybe two at the most. Okay. Anything else? So, the struggle that's going on right now is some of it is a huge struggle in our healthcare environment. That Act 48 did declare healthcare as a public good, so it does exist in our statutes that it is a public good. At the same time, we don't want to lose. We do want to make it very available and affordable for patients, but as we've heard from Jessica, it's difficult right now in this financial climate that Corey Gustafson brought up with out-of-pocket and premium costs. It's very difficult for patients to pay for healthcare, and then, as we're hearing from our providers, reimbursement is insufficient to keep them alive. So this becomes a catch-22. And so how do we ensure that we have sufficient funds to support our providers and at the same time make the healthcare affordable for our patients? And then the other thread we're hearing, which is critically important, is how do we link up our healthcare providers, our acute care, our chronic care, our clinical providers with our social service agencies. So that's another thread. That thread, which is the consistency thread when you're a patient going from one place to another, that one sometimes isn't apparent to patients. So there's a lot going on, and we'll just keep plugging away. Senator Cummings.
I've probably been here along with Chair Mullen too long. We've been through these battles before. I spent 5 years, I think, trying to get pharmaceutical costs down in this
Yep.
state. We're hearing on one hand that the cost is too high for patients, and it is. But on the other hand, we're hearing that reimbursement is too low for doctors, especially primary care docs. And I think you find that the more they depend on our Medicaid rates, the less affordable their practices are. And we do have one dominant hospital. But I think we also need to keep in mind, as we talk about affordability and availability, the models we used to look at were Europe and Canada. And in those countries, people pay 50% or more of their income in taxes. Americans have a very different attitude towards taxes. And that's a struggle we've had, but that's how you socialize the cost. That I may not need it today, but I sure will need it tomorrow. I just received my daughter's bill. Thank you, Vermont State Employees Insurance, but her bill for probably 4 weeks was more than the average Vermonter's annual income. That's just what the cost is, and that's frightening. And I'm not sure how we get there, but we're not going to solve this on the cheap. And that's where every plan that's come up before, the cost has come in and everybody has gone into sticker shock and the idea has been dropped. It's happened twice before. And we just need to be cognizant of that as we embark again.
Well said, Senator. I've been through it with you and with Chair Mullen as well.
You have?
And but there's also hope for moving forward. And that's what our goal is, to continue to move forward and to make improvements along the way. Oh, it is 12 o'clock. And I'm going
I have another meeting.
So do I. So thank you all for being here. This has been an enriching morning. And I'll see you later. Nellie, we can go off YouTube. Thank you. Thanks for being understanding.